um, who is the incident director of COVID-19 response from Public Health Wales, and he's also a good friend of mine. I'll be introducing him later. I welcome him to the program. Thank you for consulting and being with us during this holiday visit to India. Welcome, Anand Girishankar, on behalf of our institution and department. I welcome you.
Thank you.
We have with us Dr. Shalini Nui, who is the Vice Principal and also Professor of Community Medicine, who has joined us on this occasion. Ma'am, welcome to this program. I welcome Dr. Ram Prasad, who is the Director of Ramaiah Public Policy Center, who is joined in person to witness this program. Thank you very much, sir. I welcome all the colleagues of mine from my department as well as other departments who have joined us for this program. I welcome all the faculties and PGs of other departments and of the institution, and also we have people who will be joining us from the other institution as well. Welcome each one of you who have joined here in person as well as offline, online for this program. I am sure this will be an eye opener for us, and we will lots to learn from what has been the experience of Dr. Anand Giri, who was in the helm of affair of COVID pandemic in Wales. Let me have the privilege of introducing the speaker for today, Dr. Anand Girishankar, who is currently the Incident Director for COVID-19 response at Public Health Wales, who is based in the Cardiff, UK. He is also the professional lead consultant for the health protection and oversees the national operational delivery of the health protection functions of the organization. As the Incident Director, his role involved in the overall pandemic control strategy of the organization, and it involved meticulous control measures, advising on their implementation and evaluation during the COVID pandemic. He was also responsible for overseeing the response to the pandemic on a daily basis, which continues now as well. It involves a lot of coordinating outbreak control actions, including specialist health protection advice given to a range of local and national partners. He is also involved in the advising to the senior civil servants and policy officials of the Welsh government, the chief medical officer for Wales, and through them to Welsh ministers as well. He was the expert member of Welsh Technical Advisory Cell, which provides advice to the Welsh ministers on various pandemic control, and his expertise is specific in the communicable disease control, outbreak management, surveillance, and field epidemiology and risk communication. He was nominated spokesperson for the organization, and he would provide regular briefings and interviews to local, national, and international media houses. Dr. Anand Giri has 22 years of experience in the field of public health, and especially in the communicable disease control. His specialized interest is in the research and published numerous scientific articles in peer-reviewed journals. He has graduated from KIMS, both undergraduate as well as community medicine, and is excelled with distinction in first rank for the state. And we also pursue deployment of national board examination in social and preventive medicine. And later on moved on to United Kingdom and obtained Masters in Public Health from Birmingham University. And he's been also been the awardee of Fellowship of the Faculty of Public Health of the Royal College of Physicians. So currently he is the lead consultant for health protection and communicable disease control and incident director of COVID-19 public health base and UK. Recently he was awarded by one of the prestigious honorary membership of the most excellent order of the British Empire, which is to be given as MBE, which will be conferred in this current coming year. Congratulations, Anand Giri, on this. I will the state for further ado. And incidentally, he's also my colleague and a fellow colleague in the UG as well as PG. We're happy to have you and proud to be there in the ESMA in the COVID during the pandemic in the Wales. Welcome. Thank you. Thank you very much. May I now kindly request our speaker for today, Dr. Anand Girishankar, to take the slide.
Thank you, Lalita, for such an elaborate introduction. I'm not sure I'm worthy of that level of exhaustive introduction, but it's very glad and I'm very happy to be here today to share some of our experiences from managing the COVID pandemic. Obviously, everybody in the last 20 months have been pretty much involved in the pandemic response in various aspects. Therefore, the richness of learning and experience that comes from each of our own individual experiences is worthy of sharing. And therefore, this my sharing of the experience of the Welsh response is to be seen in the context of what had been done in that particular context, but very eager to also hear from all the colleagues who are present here or online as to what their individual experiences have been in their own area of response. So, Dr. Lalita and Dr. Shalini, all good friends of mine, we trained together, so it's really nice to be able to come here and at their request to share some of our experience. I was asked to use up approximately 40-50 minutes of time to share these, and I think I would also welcome very much some interactions in the form of any questions, clarifications, or sharing anecdotes, experiences from all the participants as well. So with that in mind, I think I'm going to just there seems to be some glitch with the technology, as is always the case. But just to say that by way of context, I think it's always quite tempting to make direct comparisons of a pandemic response in a particular country with a different country. But there are some aspects of that which can be easily compared directly, but a lot of the things have to be contextually interpreted. Therefore, I would just urge caution, say that if something works in a particular country, it may not work because of the prevailing circumstances there. Therefore, if you are trying to draw parallels of response standards or response outcomes or effectiveness of responses, you always have to keep in mind the demographic, social, political, cultural context in which the pandemic is unfolding. So with that, I think I just plan to cover 4 brief areas to just give a very quick overview of what is the current situation in Wales. But before that, I also wanted to throw in a little bit of organizational setup, because not many people may be familiar with the health architecture, health infrastructure, and healthcare organization delivery in UK and indeed in Wales. And then what's the current situation? And then the main focus would be on sharing the learning, which is both the learning from last year and also the learning today from this year, and a bit of personal forward look. I also want to share, because most of my has been one of the leadership role as an incident director. So some personal reflections from me on what it takes to provide some effective leadership during a pandemic are those sort of things I want to briefly cover. So for those of you who are not familiar, Wales is one of the 4 countries in the United Kingdom. Often people think United Kingdom equals England, but that is not the case. It has got 4 component countries: England, Scotland, Northern Ireland, and Wales. So Wales is where I work. Cardiff is the capital city of Wales. It has got a population of 3.1 million, and in the organization of healthcare, Wales is governed by a Welsh government, which is devolved function, and overall UK governance is through UK government in London, Westminster. But each of those 3 nations have their own governments, their own parliament, their own ministers, cabinet, and they are able to make policy decisions on a range of subjects which are devolved in function, health being one of them. Others include education, for example. There are certain functions which are not devolved, and they are same and common for the whole of the UK, such as defense, finance, and criminal justice system, etc. So we have to interpret that in the context of the devolution. Within Welsh government, there is an annual spending of approximately 15 billion pounds each year, half of which approximately 7.5 billion pounds is spent on health and social care. So health is a major player in the Welsh context. We all know that public health and politics are inseparable. Therefore, a lot of policy foundations on health is heavily dictated by political considerations as well of the prevailing government. There are 10 healthcare trusts in Wales. 7 are identified as health boards and 3 as health trusts. So the 7 health boards in Wales are shown here in this map. 1 in North Wales, 1 in Mid Wales, 1 in West Wales, and 4 in Southeast Wales. Apart from these 7 trusts, there are 7 health boards. There are 3 trusts. One is called Public Health Wales, which is where I work for. The other is an ambulance trust, and the other one is a specialist trust for cancer treatment. Public Health Wales, the organization that I work for, is relatively small organization compared to the health boards. We are around 2,000 employees pre-pandemic. We have an operating budget of approximately 120 million pounds a year. Within Public Health Wales, health protection is a specialist division, and I head that division. In my team pre-pandemic, there are about 90 people, and my operating budget is about 6 million pounds a year. Post-pandemic, or during the pandemic, we've added a lot more staff. Currently, we are heading towards approximately 200 people in my wider team. So we probably form about 5 to 7% of the organization. Public Health Wales has got 3 statutory functions mandated in legislation. First of which is to provide protective services to the population of Wales from a range of communicable diseases and non-communicable threats. Then we've got a function to carry out surveillance on a range of actions, activities, healthcare events. We also have responsibility for improving the health of the population through dedicated health improvement, health promotion activities. So my area of work is restricted to health protection, which is mainly around communicable and environmental health hazards. Within Wales, in addition to the 7 health boards, there are 22 local authorities. These are locally elected local bodies, which are independent, and they are there to serve a range of functions, including social care, employment, economy, transport, education, so on and so forth. So these are the 22 local authorities. Yes. So that's roughly the infrastructure. In terms of the delivery, in most of the healthcare provision in the NHS and indeed in Wales is state funded, free at the point of delivery, but it is through a contributory scheme where the people pay national insurance, roughly 6 to 9% of their income. The government adds on top of it grant in aid, and together forms the health spending budget. And the annual outlay is defined in every financial year, and we've also got some emergency funding for pandemics and epidemics as necessary. Those can be tapped into. The provision is largely state funded, around 98%. So that means there is very little private healthcare provision, only 2 to 3%. That is important to, if you're drawing parallels to the Indian system, here we know that a lot of healthcare is out-of-pocket spending, a little bit through contributory insurance, and a significant or slightly significant proportion through government infrastructure. So that's, and then we've got primary care. Within the 7 health boards, we've got roughly 500 GP practices, general practitioners, who see anywhere between 2 to 4,000 patients on their books. And we have 19 hospitals and a couple of medical colleges, which are having their own associated tertiary healthcare as well. Overall, at any given time, pre-pandemic, in each time, there were about 10,000 beds available in the whole of the NHS in Wales, and about 150 intensive care beds. So this is all pre-pandemic. So, NHS in Wales, across the 10 health bodies, employ between 85,000 to 90,000 people. NHS is a major employer in the country. So that's a very brief overview of the context in which this pandemic has evolved. So if you look at where are we today, the very latest data, we've had a total of just over 250,000 confirmed cases in Wales since the start of the pandemic. If you compare that to what numbers you probably see here in India, this may sound very minuscule, but these are numbers, not rates. But when you convert them into rates, you'll find that our rates per 100,000 population in Wales is significantly higher than what has been observed in India. Mortality-wise, just about 5,600 individuals have sadly died of COVID. But again, there is a difference in about how you define a COVID-related death, and I can explain that a bit later. But the biggest success story for us so far has been in the vaccinations group. Out of 3.1 million population, if you take away the under 18s, which make up roughly 900,000 population, that leaves us with just over 2.1 million, and you're nearly there with double dose vaccinations. So as much of the eligible population as is available have been vaccinated in record time, which has largely been responsible for us in mitigating what could have been potentially this third wave. So at the moment, if you can see between June, July, and August, our case rates went up, rolling the average 7-day case rates, just under 200, came down and it's not going up with the percentage test positivity approximately 13%. It's important to note that these are infections. They're not necessarily getting translated to hospital admissions or intensive care admissions, and they're not in need of any additional oxygen or mechanical ventilation. As is the case in most countries, you'll also see that a national picture tells you one story, but there are regional variations, which is also seen here in Wales. There are some local authority areas where the incidence rate is quite low, whereas in others, which is 2 times the national average. Accordingly, positivity also ranges from about 8% to close to 20%, where almost 1 in 5 tests coming back positive. These are current data, and I'll just show the last year's data in a minute. This is how the epidemic curve looks like for the last 3 months, June, July, August, and you can see those fluctuations in case numbers between 800 and 1200 each day. And in terms of corroborating the diagnostic data with untested community infection, we also use other sources of data, which is through a symptom tracker, which is produced by Imperial College in London, which is extensively used. People can download these apps on their smartphone, and if they are having any COVID-specific symptoms, they can log into that. So we record data quite regularly from that. This is percentage of people in the age group of 20 to 70 who show some level of COVID activity. And if you look at it, the darker the red shade, higher the proportion of people with symptomatic infections. And you can see this is Wales and this is the rest of the. So this again helps us determine whether incidence rates and positivity rates are actually true reflection of what is happening in the community, or are they function of limited testing? And we can pick up and match what proportion of diagnosed cases are there, and for each diagnosed case, how many undiagnosed cases there are in the community. We all know that diagnostic cases are just tip of the iceberg. And this is just a noisy graph, but just to illustrate where are the new cases occurring, who are getting infected. And this is mostly seen in our residential homes and care homes. If you see them last year, predominantly in our first wave, the purple bars represent residential homes. These are homes that are used by elderly people for their end-of-life care, or for whatever reason they are not in their own homes. We have roughly about 1,060 care homes in Wales, and lots of elderly people live there. And when we saw this, and then in the summer of last year, there was very few cases. Again, when the second wave emerged, we saw a lot of this in hospitals cases, and also when schools reopened, we did see a few spikes in school cases, but those did not necessarily translate to hospital admissions. This is the same graph, but this is for a slightly shorter period for the last month, from July to August. And here you can see they're mostly in residential homes. This also represents a fraction, because these residential care homes are where people are highly vaccinated. And still, as we know, vaccination does not provide sterilizing immunity. Vaccinated individuals can still pick up the virus. The virus can multiply and they can pass it on to others, but they themselves will not suffer from the serious complications. We don't see much school activity here because it's summer holidays in UK now, and the schools are closed. We are all eagerly waiting to see what happens in the first week of September when children go back to school. Mortality-wise, I think this is, as I said, we had reports of roughly 5,600 individuals who were dying. Much of those, nearly half of those were in 4 of the 7 health board areas. The last couple of months, we had very little cases. These are, if you look at the y-axis, it's 0, 1, 2. So we just a bit of noise there. But in July, August, we've seen a little bit more than what we saw in June. As you all, again, will be familiar that mortality is a lag indicator. You've got community infection first, then there should be exponential growth, transmission. A proportion of those will then end up in hospital, and a proportion of those will sadly go on to die. Therefore, by the time you pick up mortality as your indicator, it's a reflection of activity that has already happened in the community, probably 4 to 6 weeks earlier. So what we're seeing now in August is probably a reflection of what happened in June. This is a busy slide, but I just want to focus on this last column here, which represents testing episodes per 100,000 population. Often we use this as our benchmark to say whether are we testing enough people, are we testing the right people, and what is that telling us? Often you see that if there is a dip in case incidence, you will be asked the question, is this a true dip or is it a function of less testing? And therefore, we always try to keep testing episodes quite high, and we'd like to aim to do this roughly about 2,000 per 100,000 population episodes. And when you test high number, when you test the when we test high numbers and you still see positivity low, and when you see other symptomatic sources of that also going down, it will give you more reassurance that it's a true reduction in infection. Whereas if you have lower rates with lower testing episodes, that's not quite as comforting. So you'll see some of these where we got dark green bands, 1800, 1700, 1600 testing episodes. And then where you see if you increase the testing and decrease the positivity, that's the position we want to go to. It's okay. I can make it. It's okay. That's fine. Then just a couple of slides to just show the current situation. We use the case doubling time as one of our indicators, and you'll be familiar that if case doubling time is less than 7 days, it is seriously bad. We think it's exponential growth. It's likely to swell up your hospitals. It's going to overwhelm your health systems. And ideally, we would want it to be as high as possible. It's numerically high. So the longer time for doubling. So currently, we just under 50 days for case numbers to double. At one time in our second wave, we had case doubling time 7 days, and it was quite challenging at the period. The other estimate we use is the reproductive time p-values, and as you know, if the value is less than 1, it indicates a shrinking epidemic, and any value more than 1 is an expanding epidemic. And our challenge, we find one of the learnings for us was that with aggressive interventions, you can actually get the R value down below 1, but it is difficult to maintain it below 1. It always fluctuates, as you can see from these graphs here. It's been hovering above 1, and currently it's just over 1. With our reproductive number, you will also be familiar that numerical increase from 1.2 to 1.3 will have a much higher magnitude of impact. It's just not a simple case of a decimal point increase. The impact is quite heavy. So that's where we are currently in Wales. But if we just cast our mind back to last year, what were the major challenges and what did we learn from that experience? So I'm just trying to put all the 3 waves in one graph here. So if you look at this graph, these are confirmed cases by sample date, starting from March 2020 to August 2021. And you can see there are roughly 3 waves here. You see that the first wave is slightly lower, and the second wave is the biggest, and the third wave is bigger than the first, but not as big as the second. What this was clearly saying is our pandemic started in March last year, 27th of June, 27th of February was the first case we had last year. And unlike other countries, our source of first case was imported infections, not from China, but one from Italy. And February, March is winter months in the UK, most European countries. And skiing is a very popular sporting activity for holiday period. A lot of the UK nationals go on skiing holidays to the Alps, and one of those was where the initial cases came from. We had multiple incursions of infections. We later found out through genomic analysis that we had nearly 56 different introductions of infection into Wales in the first wave. We could not test everybody at the time because our lab capacity was limited. And that is one of our biggest learning, is that in managing the pandemic, the pre-pandemic preparedness is important. And our lab capacity, we were able to test for this very rapidly. 7th of June, 7th of January was when the WHO released the full sequence of the SARS-CoV-2. 21 days later, 28th of January, we were able to run our RT-PCR test. But the capacity was limited. We could only test 120 to 150 cases. We didn't have enough high throughput platforms. We did not have enough reagents. When I say we, not just Wales or UK, the entire Europe, there was a shortage of these. There were some countries who were better prepared. For example, Germany, by about 15th of January last year, they could do 700 RT-PCR tests a day. They had so much of network and they were able to do. Other countries who had SARS-1 experience, they were able to do it well as well. For example, Singapore, South Korea, Hong Kong, Vietnam, they all had some experience of previous pandemic. Therefore, their level of preparedness was slightly different to us. So that's one important learning for us. Second is, we had high mortality in our first wave because this was a new virus. It was sweeping through a naive population which had no prior immunity, and especially in care homes, residential homes, where elderly people with lots of comorbidities, we did lose a lot of people at the time, which I think was slightly different to the Indian first wave, because in India, our first lockdown was also same day as in UK, 23rd of March. And at that time, the number of infections in India was very, very less. Therefore, having a very aggressive all-out approach prevented a lot of deaths in India in the first wave. But I think sadly that did not translate to the intended benefit in the second wave. Whereas in European countries, they burnt their fingers much badly in the first wave and got better in the second wave. So that's just for comparing and contrasting. Then we had in the second wave, when the lockdown finished in the first wave, in the summer, which is June, July, August, we had hardly any cases, 0 cases. But then there was so much pressure on government to open up the economy. And this is one more learning, how aggressively you control one disease and you achieve some good results, but at what cost? What else will give way? What else happens, And then we had to, the government decided to open up the economy, international travel, also welfare schemes, more mixing, more social interaction. Schools opened in first week of September. We started to see our second wave. And one of the things we also learned now in hindsight was that if different districts have different incidence rates and positivity rates, applying local lockdown measures had limited impact because people movement, population movement, either for work, recreation, school, or various other reasons, are always going to negate that. So when people move, the virus moves with them. So that is one more learning. That one of the things that work for us is either we go on or none. Full lockdown or nothing. Intermediaries don't work. They may work for some time, and it may be good optics for politicians because they think that we can keep parts of the economy running, parts under lockdown. Really, I'm not sure there is enough evidence. That's something for you maybe to compare and contrast, because we see a lot of things discussed in the media here about night curfews, weekend lockdowns, limited geographical lockdown. But of course, the context may be different, but there isn't really a strong evidence to suggest that those those limited interventions may not work. Then the case numbers began to. Then we introduced for a 2-week period what we call a fire break, which was a sharp focused lockdown to bring the rising rates down. It did have its desired effects, but that desired reduction was only short-lived. No sooner did that fire break was over, cases started to go up again. And at that time, we thought that the population behavior was what was driving that, in the sense that people who had to be adhering to social distancing, we had something called the rule of 4. No more than 4 people could meet in restaurants or indoors. and no more than 6 people could meet outdoors. But then we thought some people may be gaming the system and trying to be meeting, and it was population behavior which may be driving that. And therefore, our focus was mostly on driving home that risk communication, behavior change type actions that we wanted. But in hindsight, this was in November, but towards the middle of December, we learned that not only was it due to population mixing and interaction, but there emerged the first variant, which was the Kent variant or the Alpha variant, as it is now called, the UK variant. So that we will be able to detect by about second week of December, although that genomic surveillance tells us that it was in circulation from about end of October. So it is important to have a very sensitive genomic surveillance to spot these new variants before they take a foothold and transmit rampantly. So most of our pre-Christmas wave was driven by Alpha variant, the new variant, which we knew was at least 30% more transmissible than the Wuhan original strain. And you know all about variants. I won't go into those details. There's a lot of those critical mutations around the receptor binding sites, which was causing those increases. Therefore, what then happened was the government was forced to put a second lockdown just 1 week before Christmas. So again, the public narrative around that was important, because up until then, in November, the narrative was that people can have, because Christmas is a big festival in those countries, people were gearing up for Christmas, and the government kept providing the message that we can have a lockdown-free Christmas. And therefore, perhaps people had that preparation in mind. Pre-Christmas shopping is a big thing, lots of interactions. And therefore, when the lockdown was put just 1 week before Christmas, it did not go down well with the population. One of the learning for us is that, from that is you can't make far-fetched predictions about what will happen 6-7 months down the line, let alone 6-7 weeks down the line. So that's important to have the right public narrative. And that was one of the lessons for us to learn. And when the second lockdown was put in place, it did give the desired effect, which was to bring the incidence rate down, which you can see again gone down really well. But at the same time, the question always remains, once you introduce lockdown, how long do you keep it for? When is the right time to lift the lockdown? These are really critical policy questions, and there is where the health community comes into play. We should be able to provide really robust scientific data to tell us what the modeling can look like, what shape the epidemic may take, and when you can release the lockdown. At the same time, when this was happening, 8th of December, we also introduced vaccination program. So first vaccination started 8th of August, 8th of December with the Pfizer vaccine. And then 4th of January, we introduced the Oxford AstraZeneca vaccine, marketed as Covishield here, 4th of January. And the idea then was to decide how long do we keep the lockdown. So the main issue under consideration was how fast can we vaccinate the vulnerable people and protect them, and then that can determine how soon we can lift the lockdown. So it was a race, really a race between the virus and the vaccination program. And that is where I think what the biggest achievement and success stories for us was there. The logistical planning was absolutely meticulous. We knew vaccinations would be licensed for use sometime around December, but not knowing exactly when. Preparation for that actually started way back in June, July. And you will appreciate that there are some cold chain logistical challenges with Pfizer vaccine maintaining the temperature and being suitable for mass vaccination. You couldn't get people to the vaccine, but you could take the vaccine to the people, and those challenges was really difficult. So our advice to the ministers at the time was that keep the lockdown as long as we think we need to vaccinate the elderly population. So 18th of December, I think the lockdown came into effect. The first release of that actually happened on 24th February. That was for preschool children. And then March the 8th for primary school children, and then subsequently secondary school children. And the full set of lockdowns on the way with some restrictions only got released on 9th of August. So the full restriction that came about on 16th of December, we went back to level 0 or baseline only 9th of August, just last week. So it has taken us nearly 9 to 10 months for us to go from full lockdown to full release. And in that whole process, you did partial unlocking in a phased manner, guided by the science, guided by your surveillance, and guided by the behavior of the different variants. So this one thing about I can keep a country under lockdown for a few weeks, then I release it and somehow magically the virus disappears is a myth. So they do more harm than good. Unless you have a real clear strategy, it will not work. And then, I'm sorry, I just finished the story here. So once by March we started to release, we had really low cases again, similar to what we saw in last summer. But then when we started to partially unlock and then now fully unlock, we're seeing these increase in cases. This was on expected lines. This is not a surprise at all. This is all cases in younger adults who are not yet eligible for their vaccination. I'll explain in a minute how the vaccination program rolled out. But the biggest benefit we are seeing is very little of this community infection is actually translating into hospital admissions. People are suffering minor symptoms. People are having those symptoms for fewer days. Even those that end up in hospital will not necessarily go on to get intensive care, and the length of stay in hospital is also reduced. So all of that goes down to just purely the effectiveness of the vaccine. And therefore, we cannot stress enough how important it is to roll out vaccine at a large scale and at a fast pace if we are to achieve some meaningful impact at the community level. So again, this is just another data showing how we had very poor testing in first wave, therefore we detected very little cases. When testing got better, we saw more cases, again, reflection of community transmission. Second wave, third wave, you see, we are testing more people, but only a smaller proportion are testing positive. What we want to see is these green bars be very tall and these purple bars should be very short. So we're testing more people, finding less positives. Mortality was really, more pronounced in the first wave and in the second wave, very little in the third wave. The median age for death when the Welsh data is about 81 years. The population life expectancy at birth is about 77, 78 years. Most of the deaths happened in the 70 to 79, 80 to 89-year-old group, roughly 50-50 male and female, and not much at all in the under 40s, even in the second wave. And that's where I think the contrast is for the Indian experience with the other ones. Whereas this second wave, the younger cohorts were protected because we learned the lessons from the first wave, where we had significant excess mortality in the elderly. And this is what I will show in this graph. If you look at this graph, this is deaths due to all causes, which is in the purple line here. And the green line is the 5-year baseline average. And the pink graph is the COVID-specific deaths. And you look at the first wave, which is here, our baseline is here, 5-year baseline, and our all-cause mortality is high. And most of that is contributed by COVID. Our mortality data was about 40 standard deviations more than expected. Unheard of. This is if there is ever a case study on excess mortality, this is it. We lost people badly in the first wave, and that was all in the elderly, vulnerable. Mostly they have 3 or more comorbidities, naive population, completely not met the virus before, and no treatment options were available at the time. There was also a change in clinical practice at the time. intensive care consultants, physicians had a lower threshold to ventilate people. And that is something that they changed their practice also in the second wave. Mechanical ventilation, invasive ventilation was absolutely the last resort if everything has failed. So maybe there was some learning around that about management. One of the challenges there is in any pandemic is that the disease agent is new. You have got incomplete, inaccurate information. So you have to take decisions in the light of incomplete information. So sometimes you get your decisions right, sometimes you don't. That's the nature of managing. Whereas in the second wave, we did see quite an excess mortality, but we also saw a slightly higher baseline because of the winter viruses. We do get some mortality from influenza, other respiratory viruses in pre-pandemic years. But surprisingly, last year, because of all the lockdown, social distancing, etc., mask wearing in place, we saw very little, in fact, zero influenza activity. Whereas this year now, we're already seeing a buildup of susceptibles, and therefore we've seen other viruses emerge early. For example, RSV, respiratory syncytial virus, we've never seen activity of that in Europe in July. We are now seeing huge peaks in that. So that's something to see. The unintended consequences of aggressively treating one particular infection may have a knock-on effect on other infections. So one of the learning from that is keep a holistic view, keep a broader perspective. Just because you're dealing with COVID, you can't take your eye off the ball of the other diseases. So some of the challenges for us at the time in the initial way was, what strategy should you adopt? Should you go for containment or mitigation? Containment is something that you want to absolutely stamp out every emerging infection and make sure there is no spread. And we attempted that. And we soon realized it was not possible. It was not possible because our healthcare infrastructure, our healthcare workforce levels were not geared up to dealing with the scale of the cases. So I explained in my team, we have about 20 nurses and few epidemiologists, etc. Our capacity was roughly, we could contact trace about 500 people a day. We were getting 1,500, 2,000 patients, 3-4 times the capacity. We simply could not do it. Thankfully, the country lockdown helped us. Otherwise, we could not have controlled, we could not have done contact tracing. And contact tracing is useless if you do it late. You have to just stamp out second generation cases. If you already got third generation, fourth generation cases, contact tracing is useless. It just simply goes out of hand. So we started with containment, but we switched to mitigation. Again, that's important to see whether, I don't think any country actually did containment very effectively for long. Perhaps the only outlier in that would be New Zealand. They had a really aggressive policy. They did not even allow their own residents to enter into the country without fulfilling a 10-day quarantine at port of entry. Then there was this understanding about the role of asymptomatic transmission. How much do these play a role, and how do we manage those? Then there was no treatment option. As I said, the first real evidence came from the recovery trial with the effectiveness of dexamethasone usage. And then at that time, again, there was quite a bit of narrative in the different countries, partially fueled by pharmaceutical companies, but partially also by lack of data. You know, some countries tell you hydroxychloroquine was one drug, some others tell you it's rubbish. Them tell you remdesivir is really good, some others tell you it's rubbish. So as a healthcare professional, as a policymaker, as a health minister, you are faced with this dilemma. Which evidence do you believe? Where is the truth? You know, and especially in COVID, a lot of the scientific publications actually took a bypass route, and you could get all preprints in all sorts of various places. And you know, some people could just conceive and deliver a study over a weekend, and you had a paper on Monday morning, and then that's it. This drug ivermectin is wonderful. Some other countries say, oh, hydroxychloroquine. So where do you draw your assurance from in terms of the effectiveness of the evidence? That again is a big learning and a challenge. Health system capacity is the other one. I mentioned at the start that we had about 10,000 beds in the Wales, about 152 intensive care beds. When we saw what was happening in Italy, for example, when hospitals were flooded with patients, people being treated on corridors, floors, etc., there was a sense of fear. What would happen if the situation happened here in Wales, etc. Therefore, we took a very aggressive but risk-averse approach and rapidly expanded hospital beds from about 10,000 beds to roughly something like 27,000 beds by the creation of a lot of field hospitals. There's a massive rugby stadium in Cardiff, and we took over the stadium and converted that into a field hospital within a matter of 4 weeks. Similarly, in all other health board areas, they did that. We spent a fortune on it. We spent 167 million pounds creating those field hospitals. But when the lockdown happened and when the case numbers came down, none of those beds were used, which is a good thing because we never ended. We didn't want people to go into hospital. But then, hindsight, you think, what would have been better use of that if we knew that lockdown would give rise to such an impact? And healthcare professionals is again a real challenge. I said we're about 85 to 90,000 workforce in the NHS. In local authorities, everybody, because of the lockdown, stopped their routine work, their day job. They were all diverted to COVID work. Even in hospitals, you could see an ophthalmologist would be roped into managing the COVID patient in as much as their skill level allowed it to work. So therefore, our workforce also expanded significantly. And this again goes back to pre-preparedness status. How much do you need for running a resilient system? Then we had this health economic considerations. For every decision, there are alternative options, as you can see. And in a pandemic, what happens, not only during the moment, but also after, there is intense scrutiny of every decision by government. So every time you take a decision, there will always be alternative options available, either this or that. If you go this way, then you will say, why did you not go down that way? So balancing those options is again really tricky. So in terms of, I mentioned these different countries took different approaches. In Europe, we followed what was called the pandemic influenza planning approach, which is the right thing to do for the health assessment and the risk assessment at the time. But what this particular pandemic has shown us is these planning approaches only help you to plan for a pandemic which can last for a few days, few weeks, or few months. I don't think there is any planning framework anywhere in the world that has been designed to plan for a pandemic that will run for 2 years or more. So this is another biggest learning, is that how do you do your peacetime pre-pandemic planning using what framework? And that is all of our emergency response plans were geared up to deal with short duration emergencies, not duration of this emergency of this long. I just quickly go through this then. So there were mainly 4 different harms we were looking from COVID: the health impacts of COVID itself. Then if you had COVID but no healthcare capacity, what would that do? Then the changes to the health and social care system, especially other diseases, and then the wider impact from pandemic. So because we closed all hospitals, the elective surgeries or elective care was postponed. And we saw a lot of hip operations, knee joint operations, cardiac surgeries, cancer surgeries were all postponed because every hospital was only dealing with COVID patients at the time. So that would have its negative impact on it. Then you had all this other thing about mental health. If you're locked up in a house for 3 months, and if you didn't have anybody, family, friends, then the impact on that was significant. Then the wider things about cancer screening, diabetes, hypertension, and other non-communicable chronic diseases, they were all taking a beating while we were focusing on COVID. But one of the things in pandemic response is if there is an event which is unfolding in front of your eyes, inevitably the attention and focus scrutiny is on that. So if people are dying in front of you, you're not worried about it. 10 extra people developing diabetes or 100 people developing some other chronic conditions you are focused on here. And that's some of the things about in public health is about the here and now versus the long term. So this is just to show that we had the waiting times for number of patients waiting longer than 36 weeks for an elective surgery. And as soon as we put the lockdown in March 2020, that number of people, these are numbers in thousands, and went up. So these people who have been waiting, they will all accrue harm from their own disease. So balancing COVID with non-COVID is difficult. And this is again drop in elective surgery. This blue line is 2019, green line is 2020. There was a significant drop in that because operation theaters were closed. They were converted into makeshift ICUs, etc. So summary of what did we learn in the in last year, 2020. I think I just put these 5 points here. One is the planning and preparedness. As we always see in emergency planning, failing to plan is planning to fail. And especially in the pre-pandemic or the inter-pandemic period. And this probably is not a lesson to share or read across to India, because the period between the Indian first wave and the Indian second wave was the most fertile period to plan better. And I think there was a missed opportunity there in terms of hospital capacity, oxygen, and we saw that play out in the world media. And I think April, May this year was significant. Similarly, as I said, even in UK, our planning and preparedness was to be inadequate to manage the scale of this pandemic. Therefore, our work we need to do better going forward. And highly effective surveillance is absolutely important. If you don't have your horizon scanning, if you don't know where your enemy is coming from, you can't be ready with your battle strategy. If you're focusing this way, your enemy is coming this way, then there's no chance. Variants is a good example for that, whether it's alpha variant, delta variant. The fact that variants will come is known, it's not new. Where will it emerge? How will it emerge? What can you do about it? How soon can you spot it? And what corrective actions can you take? Is what surveillance does. And I think we have, one of the success stories for UK and Wales is we've got a highly sensitive surveillance system, including genomic sequencing. So we didn't do so well on planning and preparedness. We did really well on surveillance. And then investment in healthcare infrastructure. Again, there are some things that we could have done better. Lab capacity is one. Genomic sequencing was really good because genomic sequencing was introduced in Wales pathogen genomics in 2013, much before all of this. So we had a very good head start around that. Whereas if you are now setting up from scratch your labs, your primers, with infusion of funding, you can buy infrastructure, you can buy a ventilator, you can buy a bed, you can buy sequencers, you can buy reagents. What you can't buy overnight is trained health professionals. That is where we all fall short of, and that's why I put workforce development as a key learning lesson. Bioinformaticians are as rare as hen's. They are really rare breed. So you have to develop those disciplines, those skill sets that you need for managing a pandemic. We can't rely on traditional workforce model of a doctor, a consultant, a nurse, a student, and helper. You need much more diversified, multi-speciality, multidisciplinary functioning for workforce. And then the last one I put here was strategic risk communication and behavior insight. Evidence from various studies tells us that people like freedom, and we live in our lives in our societies in a much more free way. So suddenly, when you have that as your lived experience for hundreds of years, and suddenly one morning government comes in and tells you, we're going to shut you in your house. You can't come out of it. If you come out of it, you saw those scenes in March last year. People being caned by the police when they try to get on the tool. That's not accepted. Our minds don't normally accept that curbing of freedom. So evidence suggests that people will comply for the first week, 2 weeks, 3 weeks, very well. What about 6 to 8 weeks it starts today? What about 12 weeks you've lost it? If you keep a country and lockdown for more than 3 months, you've got kind of lost it because people will just ignore and do whatever they want to do, irrespective of it. One of the things we also have to learn is enforcement of regulations is not the way to get population buy-in. People have to buy it and behave and make their own change. If you don't have enough people to police everything, for a country like Wales, we're about 2,500 police force for South Wales, and there are about more than 1 million people. How can they monitor? And much more in countries like India. So the best way to bring about behavior change is to communicate the risk to the public in an easy to understand way. And that's challenging. And that is further compounded in this pandemic because this pandemic is unfolding in an era of information overdose in what we call infodemic, an infodemic within a pandemic. And media has a real crucial role to play in that. And you will see that the narrative currently in most world media, India is no exception, there is polarized views. One end says this, the other. There is no moderation at all. And people, if you are a person who are seeking your health information from those sources, you either align to one path or to the other path. There is no reasonable thinking of middle ground at all. So risk communication is important because, and you would have seen so many examples, I'm sure, where media would have played a role about this drug is better, that isn't better. So many people died because of no oxygen. There were so many no ventilators. Some others said, this whole thing is rubbish. You have to see alternative ways of treatment, including in India. This is not new for COVID. It's been there for all diseases. There will be a purest form of management. There is a quack and there is alternative forms, etc. Including I saw in the media, some people were advocating instilling lemon juice into the nose for this, and all sorts of behavior come out of that. So what is it that we can do to get the right message to the population? One of the things, risk communication itself is a big topic in itself. I won't dwell too much here. About credibility of the source. Who is telling? Even today in the NHS, we do weekly, how are you doing surveys? And we find that healthcare professionals, doctor or nurse, is still regarded by 90% of the population as a trusted source. And therefore, then putting out real scientific messages. And we ask you to stay indoors, but we ask you to stay indoors for the following reasons. And we ask you to stay indoors for this long because we expect the pandemic to behave this way. And if it does that, so every Monday, every Wednesday, every Friday, the First Minister, the Health Minister, held press conferences every 3 times a week, 12:15 to 1:15. So everybody would tune into it. We would provide the briefing to the ministers and say, this is the epidemiology. This is what has changed from last week to this week. This is what you can expect to happen next week. So if you're giving that sort of live commentary about what is going on, people tend to engage better. They tend to know better, and then they probably have better compliance. Despite that, you will have some people who just don't believe in government, they don't believe in anything, and you can't do much with that. But at least you can get the majority of the population with you. So that, I think, is another big learning. So I'm just going to quickly go through how am I doing for time? Okay, quickly go through challenges and learning 21 then. So this is again, as I said, the case numbers now. This is in hospital inpatients now. First wave, second wave, much more. Third wave, not much at all. Again, this is thanks to vaccination. Same picture for ICU admissions. Same picture for deaths. This is something new I wanted to share was in terms of population compliance using non-traditional data to see whether people are staying at home. We use a lot of this. So we get the mobility data from Google and also from mobile phone providers. So we ask them, they provide, because most people have smartphone these days. You can access your location and where you've gone, etc. And they tell us, so if government introduces lockdown, are people really indoors or are they going out? One of the easiest ways you go out and look on the roads, you see less traffic, less people, you get anecdotal evidence of probably is locked down. But if you want to have some hard evidence about where are people going, this is really helpful. And this is new for us. This is new learning as well. So Google told us this data. So from these green bits is park activity. So we throughout the pandemic, we said when you are at home, at least go out once to take some exercise and fresh air. So you can see the green line is quite top. And we until the first lockdown, nearly 50% reduction in movements across whether it's retail, supermarkets, public transport, workforce. This is really good. And we didn't want this to go up below. So that was a good marker for us to that people were compliant. Then our biggest lesson and challenge in the second wave was emergence of variants. And I won't go into the technical aspects because that's probably beyond the scope for this one. But our strength has been genomic surveillance. We can sequence up to 100% of our sequenceable samples, CT value below 28 within 4 days. So that has been really helpful for us to identify Delta variants. In fact, the complete sequencing of Delta variants was first identified in UK and then shared with Ministry of Health in India, even though cases in Maharashtra were with Delta variant was there since about February, March time, but it's only in April that we found out that. So that has been our biggest strength. And when we use the genomic surveillance, we can provide these sort of graphs to public. You see this green bar is all Wuhan strain. When in December the Kent variant came, it completely replaced Wuhan strain. You can't see any green, it's all blue. That's Kent variant. When the Delta variant arrived, it replaced the blue Alpha variant. So all you can see. So we can demonstrate to people that there is live strain replacement happening, and therefore genomic surveillance is really at the cutting edge of providing such surveillance information. We can estimate the difference in R values between alpha, which is blue, and delta. And we can, if you show these graphs to the public, it tells you delta variant is more transmissible than alpha. And all of these reports in the technical advisory committee, the moment the first minister, the health minister, provided the media briefing at 1 o'clock, it finished. 12:15 the briefing starts. By 12 o'clock, this is already uploaded on our public-facing website. Being transparent and sharing the data with the public is really important to get their engagement. So that's something as a good learning lesson. And this is the variants that we do. We've got 3 stages. We monitor certain strains and a watch list. If there is some concern, we elevate that to variant under investigation. If there's more concern, we elevate it to variant of concern. So then I will just quickly skip over this. Very quickly, the vaccine rollout was another success story. So Joint Committee on Vaccination and Immunization is the advisory body to government, and they recommended 9 groups for vaccination. The first one being the elderly population, because we lost a lot of people in the first wave. So elderly to be protected was important. Different countries took different approaches. I think in India, priority group 1 was healthcare workers, not the elderly. In China, the priority group 1 was Chinese army, not. So it depends on each country and their perspective for policy on that. So we had 4 quick guiding principles. We wanted to vaccinate as many people as quickly as possible in a safe manner without much wastage. So that was our guiding principle, and through that we were able to achieve quite a high coverage. This is the current coverage. We've got nearly 100% coverage in higher age groups, but there are the lower age groups. We are getting there because their turn for vaccination only came about in May, and therefore they are still the last group to receive the vaccine. And that's why we are seeing the newest cases in this age group. So the summary of learning from that 2021 so far is again around the same things, but just wanted to add this bit about building structural inequalities. So bridging structural inequalities. That means in every society we see there is a difference in outcome between people who are most deprived and the people who are least deprived. In Wales, people who are least deprived die most deprived die 6 years earlier than those who are least deprived. So there are inequalities. In some local authority areas, we have up to 28% of children live in poverty, even today, in Wales. So, which is true in all countries. So, this, when there is a pandemic, when there is a pre-existing inequality, you add on top of it a pandemic, it creates a health crisis. When the health crisis is unabated, it leads to humanitarian crisis. When that humanitarian crisis is unabated, it leads to civil unrest. So, which is one of the biggest challenges you find is, thankfully, there was not much civil unrest in the UK. You can still see on the news that hundreds and thousands of people go out marching against lockdown, against vaccination, against restrictions. So, thankfully, we didn't probably see much civil unrest in India. But what I found, obviously, anecdotal seen from a distance, very painful is the level of aggression shown on healthcare workers in India. I had never witnessed such things, and you guys probably at the front line of it might have experienced it more firsthand. Whether it's verbal abuse, physical abuse, aggression, unheard of. How many, every morning you open newspaper, there's stories of a doctor being beaten, ICUs being trashed, that's all manifestation of public behavior when a health crisis turns into a humanitarian crisis. And it brings the worst of all the negative emotions and behavior out of people. So just a quick reflections, my personal reflections on how to provide leadership during a crisis. So one of the things you have to always remember is that this is a marathon, not a sprint. If you exhaust all your gas in first 2 months, then you've got nothing left in the tank. So you have to plan for the marathon. Most important also I found is looking after your team is really important. I haven't seen so much emotional distress in my team. I've been working in UK now for 15 years. Never before I had seen so many people in the team break down emotionally. There's lots going on. They may themselves be victims of infection. They may have lost family members. The children are not going to school. There's added, suddenly the way you live in society has changed overnight. And that is the mental health impact of that is unimaginable. It's difficult to quantify. It's very difficult. It's easy. It's only those who experience it will know. So you have to keep an eye on your team members. Personal resilience is important. I've been doing this role for 20 months now. I was able to do that a lot of various things. I got a very comfortable domestic environment. I don't have to worry about looking after kids, etc. So it's important. That is really important. And I can work for long hours. Those sort of things really help. And then you have to build trusted relationship with partners, and that includes politicians and media. They're both notorious. Those two groups, politicians and media, are the two groups which is really notorious to build trust with all the time. And therefore, if you get them on the right side, where you make 10 steps to get an effort, it's important they can make it in 1 step. But it is important to get done by you. And then you take a holistic and long-term view. You are not here just for the here and now. What happens today, tomorrow? What focus on recovery? What will be the society thinking ahead? That is important. And creating the right narrative. This is in the public risk communication space. If you don't tell people why you want them to take certain actions, there is very little chance of you getting any success in it. And to do that, you have to have the right narrative. In the first wave, our narrative was stay at home, stay safe, and protect the NHS. So all our narrative was saying that if you don't behave well, if you don't adhere to the guidance, there will be a lot of people ending up in hospitals. You will not get a bed, you may die. So that was the narrative. So you just need to do it. And then time is important. You have to prioritize ruthlessly because in a pandemic, you're just going from one thing to the other. You're working 16, 17 hours a day for weeks and weeks. You're going to get tired. And a lot of people come as distractors. They think everything is important and urgent. Therefore, you have to have this thing differentiate between the important and urgent. Only do the important work which is urgent, which is unimportant work, just do it. Otherwise, if you go with the approach that I try to do everything that comes to my desk today, you can't achieve it. Absolutely. And then you have to take speedy decisions, speed over perfection. You should not let the good be the enemy of the best. So never mind, you take 10 decisions, you get 7 right, 3 wrong, it's fine, it's acceptable. But the risk of inaction is far more impactful than risk of wrong action. So that's why speed over perfection. And it's all about people. You can only do this if you tell the narrative that we are all in this together. I'm not doing this just to get my award or my glory. It is everybody has to work this tirelessly. Only then we can. There's no call for heroism and this altruistic attitude there. Then the other main thing is, at every periodic moment, you just pause, reflect, and say, how has my last 6 weeks gone? What have I done right? What could I have done better? Debriefing after action reviews, etc. So that you just keep practicing. So I think we stop here. Hopefully that was, this is something I wanted to just say. What will happen next? We are in for a bumpy road ahead. We have to learn to live with the virus. We have to accept the fact that we're moving from pandemic to endemic, annual boosters, new vaccines, future waves, and acceptance of the new normal. By that I mean, I just saw this picture in my father-in-law's house last week. I picked this, this is never seen this, hanging masks. So we don't want this to be the new norm, but at least we can try to avoid by being proactive. So I'll stop here. Thank you for your attention. I'm happy to take any questions.
Thank you so much, sir, for that very comprehensive overview of how the pandemic is being managed. I feel it's time for us to widen up in some place of other nations. The floor is open for questions. Any questions or discussion?
Excellent, Dr. Anand. Thanks a lot. What would your key maybe advice for India? Right now we are in the gap between waves and we should probably expect a third wave too. So what do you think would be the key points which would help us do better with this?
Yeah, thanks, Arjun. I think it just, it's no brainer, but I think the topmost priority should be to vaccinate as much people as quickly as possible so that we build up a significant level of protection. That would be my absolute number one recommendation. Then in anticipation of a third wave, because we are such a large nation and it takes time to achieve the level of coverage, but we have to anticipate a level of infection. Therefore, as accurate and modeling as possible based on transmission dynamics, incidents, prevailing variants, level of susceptibility in the population, match that and map that with healthcare infrastructure, not just physical infrastructure, but also healthcare workers, because people are tired now. And another wave, like what happened in April and May, which is going to destroy the soul of our health workers, because it intense 12-hour shifts in a PP, in an ICU is not a joke. So we have to build as much as possible. You can't clone people overnight, but at least some level of early indicators, early warning indicators, and some circuit breakers. If it reaches this level, we're going to switch off this. If it reaches the next higher level, we're going to switch off those. Those sort of modeling and mapping that against existing infrastructure would be my second recommendation. And the third one is, I think we have to do much better in risk communication. Because we're such a diverse nation, we've got such wide cultural and cultural variations, attitudes to disease. We need to have really tailor-made local communication strategies that will help people understand what is happening, why is it happening, what is expected of them, and what will government do in return for that, and for how long do you think this will carry on? Those three would be my top messages.
Thank you.
The last Like I was just telling Harish that he's our associate dean who led the COVID hospital completely. And whatever things, all the challenges he had to face. What are the challenges you had to gear up your healthcare purpose? Because that was one of the biggest challenges which we had, of course, everywhere we had. How did that met together? Because as you said, ophthalmology is treating. Here we are not only ophthalmology, but anatomy, physiology, biochemistry faculty also were there in the COVID wards during the second wave. How did you?
Yeah, no, that's a really important question. I think the biggest challenge we had was in the time period March to June last year. The country went into lockdown in March. So when we started to reopen and commence contact tracing, it was 8th or 9th of June. So in that intervening period, we had to mobilize a workforce, roughly about 4,000 people, just for contact tracing. 4,000 seems like very small compared to the Indian context in terms of numbers, but it's huge for Welsh context. So local authorities, everybody who had a job had to drop their day jobs and had to come forward. And then we had to set up a lot of training sessions because they are good at, local authority. There's some colleagues are very good at health, so they manage communicable disease, but others are mostly involved in noise, and, air pollution, trading standards. Those guys don't have much knowledge about health, so we need to bring them, train them up, including our own medical students and master students. We also opened up the opportunities for recently retired employees, nurses, doctors, and we said we come forward. And those whose registration had lapsed, we could fast track renewals for them so that they were licensed to practice. And we got in a lot of locums at high rates. And the social care was particularly challenging because it was difficult to get caring staff, carers. But what helped was because the hospitality industry had been closed, whether it's restaurants, bars, pubs, aviation industry, hotels, a lot of people were unemployed with that. So we diverted that workforce for social care, and we did that. So that's how we managed. It still felt a bit inadequate because we still wanted more people, but at least we managed to divert a significant proportion.
Any other questions? Thank you so much, sir. And if there are no more questions, we will.
Is there anybody online who wanted to ask?
We had a small technical glitch, so we will share the recording with the entire.
Okay, that's fine.
Now, can I kindly request some dignitaries to share the stage today? Sir, can I request you to kindly take a seat on the stage first? Call from Dr. Samuel Vice Chancellor, Captain to kindly take a seat. Can I request Harish, sir, and Associate Dean to kindly take a seat? And request our Head of the Department, Dr. Lalita, to kindly. For that wonderful interaction and discussion that we had today, we'd like to present a small memento to you, sir. Can I request Moivan to kindly hand over the small memento to the guest speaker? We'd like to take this occasion to be able to give a few prizes for winners of World Environment Day and World Breastfeeding operation that is concluded recently. So can I call Dr. Babita to
Dr. Priya, thank you, Anand Girishankar, for enlightening us and giving an overview of what actually happened in Wales and your experience. It's a great pleasure to have you here. Now I call upon the winners for World Environment Day competition. I would like Dr. Anand sir to give away the prizes to winners. For the essay writing competition, Ms. Pavni Sharma. Mr. Chirag Bansal. One second prize. Sahana Imamdar. Third prize for she's from physiotherapy department. First year and company from. Now I call upon Siri. She won first prize in photo competition. Photo caption it is. Miss Rohini Elemane, second, first runner-up for photo caption. Dr. Aileen Basu for photo caption. We are actually organized competition for action plan for our college for environment day. On how they would like to change upon their hostel or the college premises to better environmental. So we have two participants who won it. We have Dr. Miss Ria Sara Paul and Miss Riti Kekar. Congratulations to all winners and participants for the World Environment Day. Now I would request Dr. Shalini Chandrasekhar to hand over the prizes for the World Breastfeeding Week program. We had a poem competition and a pencil sketching competition. The poem was, we were so glad to see the participants, not just from the undergraduates, we had faculty in tight competition, and we had it in Kannada and English. It was very nice of faculty to participate. So the first prize went to Dr. Sumchekar sir. Dr. Anupama Pujar, who won the second place in poem writing in Kannada. He's from Technical Service Department. Dr. Priyanka Paniraj, she's a postgraduate from General Medicine. She won poem competition and first prize in English. Miss Isha Chakravarti won second prize in poem writing competition English. we would like to give even the participants a few certificates. So I would like Dr. Harish to hand over the certification participant. Dr. Jyoti Casey. Dr. Mridula A.M. Ms. Kushi Agarwal. Now we would like sir to give with the pencil sketching winners. Dr. Priyanka P. She won the first prize in pencil sketching. Zohra Fatima, who won second prize in pencil sketching. I also like to give the participant is Pooja R here. We have Saksham here. It was really nice of all the participants to participate in, from various disciplines and from various designation also. It's really nice of you all to participate and congratulating to both participants and the winners. Without you all, this program would have been successful. Thank you.
To mark the effort by our college and hospital in towards the COVID work, our department has tried to compile a small statistics of what has been happening to the first and the second wave until now. So on this occasion, we would like our Associate Dean Dr. Harish sir to kindly release the COVID bulletin that has been brought out to highlight the work done by our college and hospital. Thank you, sir, for doing. Oh my God, Anand, please repeat it. All the explains. Now all those things have come to an end, and we really had a very enriching session today. So may I kindly request our beloved Professor Dr. Shalini Pradesh from the Department of Community Medicine to propose the vote of thanks.
you, Dr. Priya, as you already said, all good things should come to an end. Thank you, Dr. Anand Giri. Your experiences in the field and the experiences that you shared with us was the reason for all of us to see this program so lively. Thanks to you for accepting the invitation, and not to add on, I would also like to say that Mr. Chandrasekhar, who is a health educator, retired health educator from KIMS, was the one who actually motivated him to bring him here. And I would like to thank you also. I would like to thank our Vice Principal, Dr. Shani Nui Madam, for actually consenting to be a part of this program. Dr. Harish, whom I had an association from the past 1 year as a nodal officer. In his team, I found a lot of enthusiasm to work, and it was he made me very comfortable as nodal officer in the team. I thank you, sir, for being a part of this program. I thank Dr. Somshekhar and all the faculty members who have joined us in this program, the students, the postgraduates, participants who are online also. I would like to thank all of you. Thank you, one and all. Last but not the least, I would like to thank Mr. Ravi for arranging for the online program. Thank you.
Okay, finally request all the participants here to join for a bit of high field again.